morning. I'm Monica Feit, Executive Director of the Health and Medicine Division at the National Academies of Sciences, Engineering, and Medicine. Welcome to A Healthy Exchange, the webinar series where we connect you directly with subject matter experts who can explain timely, health-related topics spurring national conversation. Today, we're going to talk about adult ADHD. This common but often misunderstood neurological disorder can impact a person in many ways, including their relationships, educational pursuits, and professional life. The ADHD label gets used a lot in pop culture and on social media these days. And you may have noticed some recent news headlines about rising rates of ADHD diagnoses in adults. In order to help you understand the big picture, we're going to break things down a bit and take a closer look at what causes adult ADHD, how it differs from ADHD diagnosed in youth, some factors that have likely contributed to its prevalence, and where we stand with various treatment strategies. The Health and Medicine Division has explored this topic recently through workshops hosted by our Forum on Drug Discovery, Development, and Translation, and our Forum on Neuroscience and Nervous Systems Disorders. These workshops examine challenges and opportunities for the development of new therapeutics. You can check out the relevant resources section of this webpage if you're interested in digging deeper. Finally, I just want to say thanks for being here. We hope you'll find this healthy exchange both enlightening and useful. And now it's my pleasure to introduce our moderator and my colleague, Amber McLaughlin.
Hello, my name is Amber, and I also work in the Health and Medicine Division of the National Academies. As Monica said, I'll be your moderator for today's event, and thanks for setting the stage for us, Monica. So for those of you who aren't familiar with the National Academies, we're a private, nonprofit institution that provides independent, objective analysis and advice to solve complex problems and inform public policy decisions related to science, engineering, and medicine. Please note that today's discussions do not constitute viewpoints of the academies, nor do they constitute advice or recommendations. Now, before I introduce our panelists, I'll also note for the audience that today's webinar will be 1 hour and 15 minutes. We're going to start off with some questions that I have for our experts, and then we'll open it up to any questions that you have in the last 15 minutes. You can submit a question at any time during this discussion by using the Slido box that you can see right below the video player on this webpage. You can also upvote any questions that you like that someone else may have asked. So let's get started and I'll introduce the panelists. So Amy Arnsten, Ph.D., is a professor of neuroscience at Yale University. Amy, thanks for being here. David Goodman, MD, is Assistant Professor of Psychiatry and Behavioral Sciences at the Johns Hopkins University School of Medicine. David, thanks for your time today.
Thanks for your invitation.
And finally, Tamara Rosier, Ph.D., is founder of the ADHD Center of West Michigan. We appreciate you being here, Tamara.
Thanks for having me.
Between the three of you, I think we have some great perspectives for today's discussion, so let's dive right in. Now, most of us have at least heard of ADHD, either through the news cycle or personal experience or with friends and family. But let's start off with the basics. So David, can you tell us a little bit about adult ADHD as a condition? What is it, and how is it different from ADHD that's diagnosed in children? And how does it impact emotional regulation?
Well, that's a lot of questions. Thanks, Amber. ADHD, attention deficit hyperactivity disorder, is a psychiatric disorder, but it's a brain disorder. It's characterized in children, adolescents, and adults with poor attention, easily distracted, often forgetful, disorganized, poor time management, showing up late, interrupting in conversations. The DSM, the Diagnostic and Statistical Manual, edition 5, has 9 symptoms in inattention and 9 symptoms in hyperactive impulsive symptoms. And in order to be diagnosed with ADHD, you need 2 components. One is a set of symptoms, and the other is the degree to which impairments are caused by those symptoms. So for adults, you need to have 5 of 9 or more in inattention and or hyperactivity and impulsivity. Now, often it's misconstrued that this is a normal human experience and we all have cognitive fluctuations. And so we all have a little bit of ADHD. Yes, that's true. It's a normal fluctuation, but the ADHD diagnosis has very specific criteria, and it's predicated on the fact you had symptoms as a child or early adolescent into adulthood. You don't develop ADHD at 25, 37, or 48. The other important aspect here is it's highly genetic. 75% of the cause is genetic. This is not a function of bad character or bad parenting. There are environmental effects that influence ADHD, but it is largely genetic and runs in families. And so it's very important to understand that for adults, and there are about 10 million adults presumed to have ADHD, only 1 in 4 are currently being treated. So I'm grateful that you and Amy and Tamara have joined us to have this discussion, because the misinformation out there is just enormous and the public needs accurate and vetted medical information.
Thank you, David. And is it true that clinicians often find it really challenging to diagnose ADHD in adults? Can you tell us a little more about that?
The challenge here is twofold. One has to do with the education and training of the clinicians. So heretofore, there hasn't really been a focus on ADHD in adults in professional training programs, whether it's psychiatric residencies, psychology Ph.D. programs, nurse practitioners, master's degree. And so we have all of these clinicians over the course of the past decades who don't really know much about ADHD. Now, because of public media, there's an increased public perception. And as a result, clinicians have had to come up to speed and learn how to make this diagnosis. The other aspect to the complexities of diagnosing ADHD in adults is that it often walks along with anxiety disorders and mood disorders, with depression and anxiety. And so again, if you don't know what you're looking at, you won't see it. And so when the patient comes in complaining, I'm anxious, I'm going to lose my job, I'm depressed, I'm going to get divorced, the clinician focuses on the presenting symptoms and doesn't go looking for ADHD, when in fact, the ADHD may be causing the impairments in the environment that are leading the person to feel distressed and anxious and depressed. Amy is going to talk about a variety of other issues that complicate the diagnostic process. But you have two folds. To summarize, it's the lack of education amongst clinicians up to the current state, and it's the complexity of sorting out cognitive symptoms as to what diagnosis go on. I don't know if this would be the opportune time for Amy to mention the other differentials when we think about ADHD.
Yes, there are so many things, David, that can impair the prefrontal cortex, which is one of the brain regions most affected in ADHD. So much of the research suggests that ADHD involves slowed or altered development of prefrontal cortex, which we need for the executive functions and top-down control of our attention and actions, and also its connections to a more ancient part of the brain called the striatum that mediates habits like muscle memory. And as you said, it's highly heritable. But prefrontal cortex is like the Goldilocks of our brain. It has to have everything just right, and especially it has to have just the right neurochemical environment. And so things like stress, especially if we feel out of control, fatigue, inflammation, and hormonal imbalances from menopause or premenstrual dysphoric disorder, all of these can cause neurochemical changes in prefrontal where it doesn't work properly. As you were mentioning, the prefrontal cortex is also impaired in other mental disorders, such as depression, bipolar disorder, especially during the manic phase, and with substance abuse. So you have to have a very clever diagnostician, someone who really knows the field, who can really determine why you're having these symptoms and make sure you get the treatment that will help, because, for example, a stimulant medication will make someone with bipolar disorder potentially much worse.
There are other medical considerations too. It's important to understand that this is not just a psychological diagnosis. There are medical conditions that present with cognitive symptoms as well. So the connective tissue disorders like Ehlers-Danlos syndrome, polycystic ovarian syndrome, and also mild cognitive impairment. And so having a medical background and training also helps in expanding the medical differential diagnosis beyond just psychiatric. But Tamara probably could tell us more about her experience with ADHD and how this is complicated seeking out care.
Yeah, I think I was off camera, David, when you were describing ADHD. I've read the DSM, I know it quite well. And yet I get a little cringy when you're describing it, because I'm like, wow, this is getting personal. This is like, he's describing me. I know I'm here with a PhD, and I know I'm one of the lucky ones that kind of had things fall in the right place. But for those of us who have ADHD, we're living in a world that is not equipped for us. I would be better living, I think, about 855 years ago. Why 855? I don't know. It sounded like a great number. So let's talk a second about getting a diagnosis. For many people, getting a diagnosis can be a turning point in their life. For me personally, I just thought I was dumb. And in high school, I just thought, well, yeah, honor society is just not for me. And that's why I was just smart enough to be able to show up at class and learn things, but I never studied. I didn't understand other people were actually studying. So I came to the conclusion, I'm just dumb. And so a lot of my clients who come to me have those experiences of I'm less than. I'm less than and too much at the same time. And so after diagnosis, this can be such a powerful moment because it shifts the narrative. Getting diagnosis later in life, and I'm sure, David, you've worked with this, a lot of my clients will kind of go through a time of grieving of what could I have done if I would have known this. So I just want to encourage people, diagnosis is not a label. You're not labeling someone, but it is an explanation.
No, I think that's very well said, that it's an explanation, not a label. That should be highlighted.
Yes, absolutely. And Tamara, I know that, getting a diagnosis, getting an appointment with a mental health professional can sometimes take months, and evaluations can cost thousands of dollars. Can you talk a little bit more about, the barriers that people face when trying to get help? And are there ways that we can mitigate some of these barriers?
Yeah, can I? The whole thing seems like a goat rodeo. Amy talked about the prefrontal cortex, and the prefrontal cortex really is this lovely modern mechanism that directs our thoughts, behavior, attention. It actually does this thing that I think is sorcery, and it plans ahead, right? And it has patients filling out forms. And so what do you have to do when you go for first of all, you have to find someone who's highly qualified. Well, that's going to take a lot of effort and searching. Some of my clients are right there. All right, I'm tapping out. That's too much. Many of the best professionals ask you to fill out forms. I know one person who's highly qualified at diagnosing ADHD. He has a 50-page form.
Gosh.
And that is really hard on my people. And 2-page forms are hard. So again, he's excellent at what he does. He needs a lot of background to do it well, but you see, that's another dynamic. So there's cost. We have to figure out the insurance. The whole thing is incredibly arduous. And for those of us who lack a regulated prefrontal cortex, it seems excessive. Now to build on that, we also have some social implications. In some cultures, it's not really socially acceptable to have ADHD. And there must be another explanation, like maybe you're lazy. And so a lot of people come into our practice already with a lot of shame of, well, I think I'm lazy, but I just wanted to check out. What if I'm not? And we really do help guide them through a lot of the process. I think something that we said earlier is we really want to make sure it's ADHD and not other things. The prefrontal cortex, having an impairment in your prefrontal cortex is frustrating, and ADHD seems like the easiest explanation, but you really want a practitioner who will partner with you and help you explore really what is the correct diagnosis here.
Great. Thank you, Tamara. That kind of leads really well into our next question, which is, David, how do you think that all of this information online and on social media about ADHD is impacting the public perception or understanding of adult ADHD? And why does this matter?
So it's an excellent question because the internet has been wonderful. It's essentially democratized information. And if you think about the methods of communication as a historical pattern, we go from the paintings on cave walls where 4 or 5 people would see the cave walls, and then you get to the conveyance of stories, and you move through parchment and the Gutenberg press and Morse code, telephone, television. And with each iteration of technology, the expansion of how information gets disseminated is greater and greater. We now have a global means of communication that is the internet. And so with social media, especially TikTok, which seems to be one of the favorite, ADHD is actually tagged an enormous amount of time. It's one of the highest tagged on TikTok. There was a recent study looking at 100 of the most popular videos on ADHD. And they had psychiatrists and psychiatric residents go through the accuracy of the information. 54% of the 100 videos were deemed to be misinformation and inaccurate. Only 24% were deemed to be accurate information. So what happens is that people go looking for accurate information and they find misinformation. They begin to think that they have ADHD because they're reading these description of symptoms. Now, remember, the diagnostic criteria for ADHD is symptoms since childhood and early adolescence. It's not something you developed, and it's not something that you have in the last week or month or year. And so that doesn't get conveyed in the misinformation and inaccurate information. And people come to believe, well, maybe I have ADHD as well. And the proof of this impact here is in a New York Times reported survey where 1 in 4 people thought they had ADHD, when in fact the real prevalence in the adult population is 1 in 20. And so people come to believe they have a disorder they don't have. The downside to that then is they go off and see a clinician who may or may not be well trained to do an accurate diagnosis. They shrug their shoulders and say, well, let's put you on medication for ADHD and see if you get better. Well, if I put 100 people on stimulant medications who don't have ADHD, 95 will say their mood, their energy, and cognition are better. It doesn't mean you have ADHD. It means I've rearranged the brain chemistry, and that's the psychological experience. If the patient comes back and says, wow, you're a genius, let me stay on this medicine because I'm so much better, you end up with people who don't have a disorder on medication they ought not have been prescribed in the beginning. And so to come back in regards to social media, it really is important for people to be able to identify the source of the information and the credibility and accuracy of that information. Unfortunately, you have the general public and teenagers and young adults and even middle-aged adults going to these sites. They look at the first video that comes up. It's most likely the first video is going to be inaccurate unless you're going to a vetted site. So that's kind of a summary of where we are. Where are we going? We hope that programs like this put out accurate information, that people begin to identify the source of the information first before they look at the information offered.
Thanks, David. And can you talk a little bit while we're on this specific topic about the role of primary care? How does that fit in here? Can someone ask their primary care provider about this?
They can, and depending on whether the primary care provider is comfortable with this. Now, Primary care had previously not wanted to participate in this because they didn't want to write for controlled substances. As the demand for an evaluation and prescriptions increased, they have grown increasingly more comfortable, but it depends on the individual practitioner. Currently, 45% of stimulant medications are written by primary care. If you go back 20 years ago, it's probably 5%. So as mental health gets destigmatized and primary care find themselves in the position of wanting to and being asked to provide care, they're growing more and more comfortable. But you want to make sure if you're going for an ADHD evaluation that the person you are seeing knows ADHD and knows how to identify that. Because again, you can't see what you don't know, and it's not your fault because you weren't trained. And you weren't trained because the people who were training you also didn't know it. So there's a real lag time here in which I say provocatively that adult psychiatry abdicated ADHD to child psychiatry, and we're all just coming around now to understanding this is the second most prevalent psychiatric disorder in adults, and yet there's not a focus in the educational training programs. I mean, Amy works in a facility that trains residents. What's your opinion about how things have transpired over the last 30 years?
Yes, I'm very aware that Yale's one of the few places that actually teaches all med students about the prefrontal cortex. Many medical schools still do not, even though it's so afflicted in so many different disorders. I also wanted to add that so much of this, I think, with the increased diagnosis has to do with the increasing demands in our culture to sit still at a computer for hours and hours and sort through huge amounts of information and do so screening out distractors in a way that for probably thousands of years humans never had to do. So I think the kinds of genes that increase an ADHD-like brain were probably even selected for centuries because they were probably helpful in many cultures. But now in the information age, they've really become a hindrance. And I am guessing that that's part of why we're seeing such an increase in diagnosis. Also, the stressors of modern life impacting and impairing prefrontal, so that there may be some people who are experiencing attention deficits really due to the stress of their lives rather than actually having ADHD.
So how would you separate that out from children and adolescents who have symptoms that continue into adulthood, which really become part of the diagnostic criteria?
Yes, so that's where a really good history is so important, right, David? That a physician will really be asking detailed questions to get at the source. Is it because you're going through a divorce, or is this something that's been a lifelong challenge and has just become a disability because now the challenges in your life are so much more?
Great, thank you, Amy. And before we switch to more of the treatment side of things, I was wondering if you could spend a little more time talking about the fact that, and you've referenced this a little, that ADHD can sometimes mimic other conditions. Can you give us a little more detail about that and why it is so important that we really understand what is happening with the person? Because what are the consequences? Let's talk a little bit more about how it can mimic other conditions.
Yes, I gave a list before, and what many things in that list: stress, fatigue, inflammation, hormone imbalance. All of these things are altering the neurochemical environment in prefrontal cortex. And it takes very little to set prefrontal off balance. It needs everything just right. And I experienced this in my own life, even over the course of a single day. I'm useless by 5 p.m. So I know if it's at all something that involves planning ahead, complex organization and focus, I better do it in the morning. And I think we all have this intuitive sense of when we're at our best and worst. And then you can exaggerate that in many conditions where it's really hard to have strong prefrontal function.
So Amy mentioned hormones, and I want to highlight that the emerging research, which had been really poorly developed for women with ADHD, and the impact of hormones. Now, what I'm about to say really has very little research publication information because there has not been heretofore research dollars funded for ADHD in women. But the clinical implications here is that some ADHD women say their symptoms get worse premenstrually. It's not for everybody. It's like premenstrual mood disturbance. Not every woman gets that. Then we have issues in pregnancy. Should you or should you not remain on your ADHD medication? And what's the implication? Then you move to breastfeeding. But in regards to hormones, it really comes home in the perimenopause time when the estrogen levels are dropping. Now, estrogen is pro-cognitive. So if you start losing your estrogen, women start complaining about vasomotor physical symptoms, but they also complain about mood reactivity and cognitive fogginess. If you have a woman with ADHD who now is in her perimenopausal time period, she'll complain her ADHD symptoms are getting worse. It's not that the ADHD itself is getting worse, it's that the change in the hormonal environment are making cognitive symptoms worse. The diagnostic differential there becomes, do I increase the ADHD medication, or do I recommend that she go on hormone replacement therapy for 3 months to see if there is a response? I usually do that in coordination with the GYN. But those are differentials that haven't heretofore been raised because the research just isn't there. And if you ask me, are there any controlled trials on stimulants in ADHD women in perimenopause, the answer is no. That's appalling. We should have more research to answer these questions. And Amy can speak to this a bit more, but the only area in the neocortex that has estrogen and progesterone receptors is the prefrontal cortex that Amy's highlighted as being a critical role in ADHD. So you begin to understand and put together this story for women. And I just want to highlight that because there is a lot of emerging research on women and the focus on this. And one of my areas of expertise is in ADHD in older adults, and perhaps we can get there later in the conversation. But those adults over the age of 50 who've never been diagnosed, who have ADHD their whole life, the medical differential, the psychiatric differential becomes so much more complex than evaluating a 12-year-old. So I'm going to go to Tamara here. So you can talk about how does this information resonate with you, and what would you like to see move forward with the research?
Well, fortunately, I had my mic muted because I would have been, you were preaching to the choir. I'm like, yep, got it, nailed it. As a female with ADHD, I experienced all those things. And the research wasn't there. And I just thought I was losing my darn mind. And it, even though I kind of say that lightheartedly, I really did wonder. There was a time in my life when I kept going back to my primary care and say, are you sure I don't have early Alzheimer's? Are you sure? It would have been wonderful if he said, no, but because your estrogen is dipping. And I felt it. And so thank you, David, for really talking about that, because we don't know enough about ADHD in women. In the research. So I want to encourage everyone who's listening. ADHD doesn't just affect the prefrontal cortex. I mean, it does, but for those of us with it, it affects every part of our life, every nook and cranny. So it affects our emotions, relationships, our confidence, just all of our daily rhythms are affected by ADHD. And this is important because, we're listing the symptoms, but this is a serious, ADHD is very serious to take seriously because, we have all these jokes like, oh, I just have ADHD today. Well, friend, that's not funny, because as someone who lives with that brain and who has like some drunken monkeys running loose, Amy, you're not good by 5. I have a little earlier cutoff and my meds stop and I need to tap out of some conversations, but it affects every single part of my life. So here's what I want to encourage people to do. Start documenting your own symptoms. You can find a list of symptoms online. You know how to do it. You can find that symptom. Start documenting it. Ask someone you trust, a spouse, parent, partner, to also observe your symptoms, and then bring that information to someone who you want to have the discussion with. That way you're bringing some kind of observations instead of just saying, well, I just don't know. I just don't feel like I can focus. Well, a lot of times when people say they can't focus, that means several different things. So if you can say, this is what I'm experiencing, it will help your practitioner help you better too.
Tamara, such good points. Very good points. Thank you. So David, let's talk about medication. We've danced around it a little, but tell us, what do we know about the risks and benefits of medication, both stimulant and non-stimulant, for treating ADHD in adult populations?
Well, that's a great question. Let me pose the preamble to that question, and that is, what is the risk if we don't treat ADHD? The risk of not treating ADHD is the following, starting from childhood into adulthood. In childhood, it causes underachievement academically and social difficulties if you're reactive or you're verbally impulsive. You're much less likely to finish high school. You're more likely to smoke cigarettes. You're more likely to get involved with alcohol and drugs. You're more likely to get arrested in late adolescence and early adulthood. You're less likely to finish college. You're more likely to take longer to finish college. You'll have more jobs over the course of a 10-year period. You're twice as likely to get divorced, and it goes on and on. I don't want to paint a horror story because there are variables that account for why some people can be relatively successful and other people's lives are just a series of hitting the walls. But it is notable to highlight when not treating ADHD will lead to a lot of negative consequences in people's lives that are very dramatic and traumatic. Now, if you treat ADHD, and we often use long-acting stimulant medications, by the way, even though people say these are toxic and addictive, they are one of the highest effect size. That is, of all the psychiatric disorders, I can treat 2 in 2 hours. One is panic disorder by giving you a sedative, and the other is ADHD by giving you a stimulant medication. So stimulant medications come in short-acting, medium-acting, and long-acting. We really try to prescribe once a day in the morning that will last 8, 10, 12 hours. We often can't achieve that, but we can supplement with additional doses during the day. If the medicine's helpful, it's like blurred vision. You put on your glasses, all of a sudden you can see clearly. Now, do you need to spend your life wearing glasses? No, throw the glasses away and you will deal with blurred vision. If the same thing is true with medication, if you take medication and it improves your symptoms and the quality of your functioning during the day, then you decide whether or not you want to stay on the medication. The issue of I'm dependent on this medicine for my brain to function, I reframe and say, look, this is a choice of quality of life. Now that you've had the experience of how your brain functions with medicine, then you can decide, do you want to function in this quality of life or do you want to function in another quality of life? And so I always leave it up to the patient to make these decisions. I'm here to provide an accurate diagnosis and information so you can make informed decisions about your distress, your symptoms, and how you want to conduct your life. Beyond stimulant medications, there are non-stimulants. They don't work quite as well. They take 2 to 4 weeks before you notice a difference, but they are an alternative for people who can't tolerate stimulant medications. The risks of stimulants tend to be decreased appetite, upset stomach, and we need to monitor blood pressure and pulse. If you happen to be somebody where the blood pressure and pulse goes up, we just need to know that. Often it's not significant, but for occasional people, it can be. All of the stimulant medications are labeled as C2 drugs. That means they have the potential to be abused and addictive. And so when I'm prescribing medications, I'm prescribing a specific amount over a specific daily dose, and I'm monitoring to make sure that you're taking it regularly. If you are abusing and misusing alcohol, substance abuse, THC, that becomes another factor in my consideration. Do I prescribe a stimulant medication or do I start with a non-stimulant medication? And beyond medications, it's skills with pills. So we need to teach people organizational techniques. And Tamara actually mentioned what I think is the most critical aspect of psychotherapy, and that is having the person finally come to the understanding of what they have, ADHD, versus who they are as a person. And that really helps resurrect self-image and increases confidence. The people around you will notice you're functioning better. And over the course of 6 months to a year, you really blossom into the person that God meant you to be, not hampered by a disorder that is otherwise treatable. I'm sorry for the long, I feel very passionate about this, and it's a lot of information to convey to people in one paragraph. But I echo what Tamara says. If you get diagnosed with ADHD and you get appropriately treated, this is transformational. I've had an older woman go back to law school and finish law school. I've had people who are going to drop out of college, complete their college degrees. I've had people who doubled their business in 3 years on ADHD medications. So this is not just putting on glasses. Here's the difference between treating depression and treating ADHD. If I treat depression, I bring you back to where you were in a non-depressed state. If I treat your ADHD, we're going to transform you into the person you hoped you could be, but never would have been able to do had your ADHD not been treated. You are a better version of yourself as a result of treatment. Sorry for my advocacy, but I feel passionately about this.
David,
David, do not apologize. That was wonderful.
David, I love what you just said, and here's why I love it. A lot of us with ADHD, it seems like people treat us paternalistically and will tell us what's good for us instead of giving us the dignity of choosing. Many times, my clients report that when they seek diagnosis, they're considered drug seeking. And it was a lot of hurdles just to get to the diagnosis, and then they're kind of mistreated. I love the dignity with which David represents, and any psychiatrists who are listening, this is the goal. Give your patients the choice, but also give them the glimmer of hope. Like, that potential you've been chasing, I've got some answers that could help you. And obviously, therapy and ADHD coaching can also build on those skills.
Thank you. So important. Amy, let's come over to you. So can you tell us a little more about, what's known about these medications, and tell us and break it down for us how they affect the brain?
Yes, well, I said that the prefrontal cortex is like the Goldilocks of the brain, and it has to have just the right neurochemical environment. And these medications work to optimize that neurochemical environment so that your prefrontal cortex works better. Oftentimes, what they're doing is increasing the availability of neurotransmitters called dopamine and norepinephrine. Some also affect serotonin, but mostly it's giving prefrontal cortex the norepinephrine and dopamine that it needs. And it's mimicking how your prefrontal acts when it's feeling rested and safe and interested in something, that really optimal state. We know from research in rodents that one of the non-stimulant medications, guanfacine, that my lab's been involved with, also can protect and strengthen prefrontal cortical connections. That happens more slowly. We think that's part of why you need to keep taking guanfacine every day, not just on a as-needed basis, as many people do with stimulants. And also that guanfacine can be combined with a stimulant medication. And so that can give you 24-hour treatment, where the stimulant you don't want to take at night because it'll keep you awake. Guanfacine has extended release preparations and if you're old enough, you don't even need extended release. So you can have a 24-hour treatment and then the stimulant on top of that during the daytime.
Great, thank you. That's so helpful. Let's see. Let's go back to Tamara. Why don't you talk about some of the insights you've learned, not just from your experience, but your coaching of others? There have to be a lot of great takeaways that you've gotten over the years. Maybe you can share some insights with us.
Nope, none. That's it. No, sorry for my sass there. You know, I'm at the ADHD center, and I see my clients come in beaten down. They feel hopeless. They feel like there's something incredibly wrong with them, and and yet they have this hope, and they have this kind of, I know what I could be, which is why when David was saying, like, we can help you, it gives hope. And so something we really want to do for those of us with ADHD is we want to help them get their hope back. I see parents who are very scared when they bring their children into the center. And then when and Amy and David, you know this because the highly hereditary, I say, well, where do you think this could have come from? And the parents kind of shrug, and I keep talking until one parent rats out the other. And then I help them understand that ADHD, living in a family where when there's one ADHD, there's many of us with ADHD. And so we really want to build supportive systems within the family so that families can learn to support each other cognitively. Some of the things that I've also learned in helping clients prepare to work with the medical community is teaching my clients to be choosy, teaching my clients to choose a partner. And if you go into an office and you're not feeling heard, go find someone else. Do your homework, go in prepared, and stay focused on the fact that it doesn't have to be ADHD. I'm not diagnosing myself, but then please help me arrive at a solution to how I'm feeling.
That's a
It
great
does
point.
speak to it,
Sorry, go ahead,
Tamara, it does speak to patients and people having a sense of what's involved in an evaluation. When you go to a doctor, you go to a care provider, you're not really sure whether the person is doing the job well or doing the job inaccurately. And so it's important for patients to understand what's involved with a comprehensive psychiatric evaluation. I will say that the Children and Adults with ADHD Association, which is a national grassroots association, have a variety of vetted resources in order to understand what's involved in the process of getting a diagnosis. And that way you can evaluate whether the person interviewing you is asking you the right questions. The other organization is the American Professional Society for ADHD and Related Disorders, which is currently undertaking the development and eventual publication of the first U.S. clinical practice guidelines in ADHD in adults, both the diagnosis and the treatment. And so hopefully when that gets published, it'll set a standard by which the public can evaluate whether they're getting the appropriate evaluation, and for clinicians, what the course of treatment really looks like. So I'm looking forward to those resources coming online, but it is important for the patients to do their research and understand what an evaluation entails so they can see whether the person doing the interview is actually asking them a lot of questions.
Really good point. Tamara and Amy, anything to add there in terms of resources that people can use or find online to help get some of their questions answered? And also, just information about the medication in general. You want to have that knowledge as well before you start this process. Do you have any additional recommendations?
I have some YouTube videos online at the Yale Medical School YouTube channel that explain what prefrontal does, how stress affects it, how medications affect it. So searching within the Yale Medical School YouTube channel for my name usually brings them up.
Great. Tamara, anything to add there?
Okay, so first of all, David and Amy took all of my answers, and they were great answers, by the way. So I would add, once you are diagnosed, join the groups that can help you keep growing. So first of all, obviously, I'm really into ADHD coaching. Find a highly qualified ADHD coach who can help you grow. There's ADA, adults with ADHD, who can also help you grow. So find your people, and don't try to do this alone. And also start the discussions in families. Like, hey, guess what? Now, don't do this at Thanksgiving. You're going to wreck Thanksgiving. So find another time. But hey, Dad, I noticed we think alike. Are you open to a conversation? I was just diagnosed. So start, having those discussions and talking with each other. You don't have to be alone in this.
Great. Such an important point, as we continue to destigmatize mental health and just brain science in general, it's so important to have these conversations in families. So thank you. So I want to move on to the last question, and I would like to hear from everybody on this because I think it's an important one. What's the one thing you really hope that people are going to take away from today's conversation? So David, I want to start with you.
I really want to focus on the education of the public and more specifically on professionals. My thrust at this point is to try to get the professional training programs to add adult ADHD as a focus in their training so that we're starting to graduate professionals who know what this is rather than spending the last 30 years trying to update those who were never trained. That is a heavy lift because of some cultural bias amongst the older professionals about ADHD. I've spent almost 40 years now trying to convey to my colleagues ADHD actually is a real disorder. It is the second most prevalent psychiatric disorder. You're not training your residents, your PhDs, your master students, and your NPs on this. And as a result, they don't know how to identify this. If you have ADHD and it's not being treated and you show up and the clinician says you have anxiety and or depression, the risk that you're going to respond to an antidepressant is actually substantially less if your ADHD hasn't been identified and treated. That means the presence of untreated ADHD reduces the response of an antidepressant. Clinicians don't know that. And so they then start prescribing more and more antidepressants, and they walk down a path that is far less optimal for the eventual remission of ADHD symptoms and anxiety. Now, you can have an anxiety disorder and ADHD. You can have a mood disorder and ADHD, but they walk together. It's not one or the other. And so my push, and I want to leave everybody who's listening to this, and obviously those who are listening are interested in being educated, is to disseminate accurate information across your own social networks, as well as anyone you talk to. And I echo Tamara's remarks, and that is if you walk in and your clinician, your provider says, I don't believe in ADHD, I've never prescribed these medications, I'm not going to prescribe these medications, and you're convinced that you had ADHD since you were a child, it's time to find a new provider.
Excellent points. Okay, Amy, let's go to you. What's the one thing you want people to take away from today's conversation?
Well, I certainly agree with David, and that the neurobiology of mental illness should be taught in med schools. So everybody, all physicians know it. But I think everyone should know that ADHD is a neurobiological disorder. And as Tamara has said, don't blame yourself and think you're stupid. This is how your brain has developed. And if it's a hindrance to what you personally want to achieve in your life, then get the treatment, because it really can help.
Great. And Tamara?
So I want to just talk to the people right now who think they have ADHD or know they have ADHD. Your brain's not broken. It is quirky. Learn the quirks and really get serious about learning the quirks. I'm going to say something a little bit provocative. there is no solid research why ADHD people should be good at anything. And yet here we are. And you see us. And so if we could reframe this from kind of this thing that just keeps holding us back, somehow we keep finding the courage to get up each morning, the kind of strength to keep pushing through, and that makes us heroes. And so I just really want to encourage people that if you were watching a race, if you were watching someone kind of run and you saw that they had a limp, would you be cheering them on? Because you're like, dude, that race is harder for you. And I just want to reframe the conversation about ADHD. We still show up. We still do grown-up things, even though I still call them grown-up things and not just my life. So I just really want to encourage everyone listening who has ADHD.
Thank you. David, I'm curious if you have any responses to Amy and Tamara. I think they made some unique points, and I'm curious if you have a response from your side of things.
I have several responses. First of all, those of you who are watching perhaps don't realize that Dr. Arnsten has contributed so much to the field over the course of, I suspect, decades, even though she's only 29 years old. And so you should understand that when Amy speaks, other clinicians and researchers sit up in meetings and they listen to her. Tamara has just been amazingly articulate in the experience and reframing. And it's what makes her a very good coach, because it's not that your brain is broken, it's that it's quirky. You got the genes, figure out what your strengths are with a good therapist, and move forward. The other thing I would say is picking a partner who understands ADHD or is at least a bit laid back and not obsessional about things is also a good thing to consider. But I think this has been a wonderful discussion, and I'm thrilled to have been part of it with Amy and Tamara.
Great. So it's time to move on to the audience questions. We got some good ones. So I'm going to go through them now, and I can kind of assign them based on, our panelists today. But again, feel free to jump in to all of our panelists at any time. So let's start with the most upvoted question. I would like to hear any thoughts about how to best manage comorbidities of depression and anxiety if using medications. Is it better to focus first on ADHD meds and hope that will address the depression and anxiety? David, do you want to take this one?
Sure. This is the chicken and egg question, and I'll help sort this out. If someone has several comorbidities, the diagnostic prioritization, that is, what do you treat first, second, and third, generally falls this way. You treat alcohol and substance abuse first. You treat severe mood disorders second. You treat severe anxieties third. You treat ADHD last. And the reason it's listed that way is because all of the cognitive difficulties you have in ADHD can also occur in all of the other disorders. The other reason it's laid out this way is that the stimulant medications or any of the ADHD medications short of the alpha-2 agents run the risk of making the other disorders that are not being treated worse. So when somebody has depression and ADHD, the question is it the depression primary, that is a disorder unto itself, or is the depression and demoralization secondary to ADHD? That you have to figure out based on the severity of symptoms. So if the severity of the depression is really bad, then you treat the depression first, then you move on to treat the ADHD. If the depression is mild to moderate and the content of your thinking in a depressed state has to do with worrying about being on time, worrying about finishing on time, worrying about performance issues, then it's likely the depressed mood is secondary to the ADHD. If you treat the ADHD, the impairments diminish and you feel better about your productivity. So that's how we would sort that out. And that then decides whether you start with antidepressant medication or whether you start with ADHD medication.
That's helpful. Thank you. And I'm just curious, as part of that question and some of the way you answered it, how does substance use or abuse, how could that contribute or exacerbate ADHD symptoms? I'm thinking that's probably something people in the audience would want to know.
So substance abuse will cause cognitive difficulties in and of themselves. So if you're smoking marijuana every day, or you're drinking a six-pack every day, and you have ADHD, your cognitive symptoms are going to be worse. The clinician is likely going to say, I can't sort out the cognitive symptoms of ADHD from the substance use. So we really have to get you off of the substances in order to figure out what the residual cognitive symptoms are from ADHD. Now, this occurs on a threshold. So if you're using marijuana recreationally, you have a couple of puffs at night for sleep or for whatever, that really isn't an issue. But if you're getting high 4 or 5 times a day, every day for several years, that's an entirely different question. If you have a couple of beers 3 or 4 nights a week, a couple, 2, that's not an issue. But if you're doing a 6-pack a day, now I've got an issue with that. So that's kind of how it sorts out. Very interestingly, though, historically we said treat the substance and alcohol abuse first and then move on to the ADHD. Recent research, both in substance use disorder outpatient treatment and opioid withdrawal inpatient treatment, suggests that if you treat the ADHD at the same time they're in substance use disorder treatment, they're more likely to stay in treatment than if their ADHD is not treated. So as the research evolves, it looks like some of this can be treated concomitantly at the same time, which actually leads to a better outcome. But we leave this to the clinical decision-making and the presentation of the patient and the circumstances of their life.
So helpful. Thank you for breaking that down. Okay, next question from the audience. What kind of specialist is the best to diagnose and manage adult ADHD specifically? Is there a certain type of specialist? Then the person said family doctors aren't often aware of ADHD in adults or how to treat it.
Well, I hate to field all these clinical questions, but this is what I do. So if a primary care, a psychiatric nurse practitioner or primary care doc has experience and has been doing this, then they can do the evaluation and come to a conclusion. Often you ought to see someone who has experience in doing this to do the evaluation and then get stabilized on medication, get a psychotherapeutic plan in place. If then you want to go back to the primary care doc, they will often assume the care. But if there are changes that need to be made, they may not feel comfortable doing that. So you're going to have to ask the clinician whether they're comfortable doing this. One of the issues that comes up is, well, I'm not quite sure what the diagnosis is. I'll send you for neuropsychological testing. That'll sort it out and make the diagnosis. That actually is not correct. Neuropsychological testing will help sort out cognitive deficits, but it doesn't make the diagnosis. So the cognitive symptoms on testing occur on that particular day, but the diagnostic criteria is you had symptoms since childhood or early adolescence in order to have ADHD. So neuropsychological tests can cost thousands of dollars. It's often not covered by insurance. And I would say you're better off spending your money seeing a qualified clinician who will do a clinical interview, come to a conclusion. Now, neuropsychological testing can be used for learning disabilities or specific deficits, auditory processing problems, executive function, or measurements of intelligence if you want to find that out. But neuropsychological test is not used to make a diagnosis of ADHD.
Great, thank you. So here's an important one. We've been talking about ADHD as a psychiatric disorder in this webinar, but someone noted that CDC calls it a developmental disorder. What's the difference? A developmental disorder implies skills to be trained, while implications for treatment of a psychiatric disorder are different, the person who submitted this states. Can someone help us clear this up?
I would say that a developmental disorder, what that really means is it's something that starts in childhood, and it's about the development of the brain. And sometimes training can help, but not always. So if you look at the term in that way, you can see that it's a subset of psychiatric disorders, and ADHD being one that is required to begin in childhood, adolescence for its diagnosis. And as David was saying earlier, oftentimes that can be more subtle if you didn't have the kinds of challenges in childhood that you now have in adulthood. So it might have been missed, but you can look back and see that indeed it was there during this developmental period, using the term development to mean childhood and adolescence.
So sometimes
Yeah.
So sometimes you hear neurodevelopmental, you hear neuropsychiatric, you hear psychiatric. These are just looking at the same disorder from different perspectives. One of the elements to the neurodevelopmental is because it's highly genetic. We've also noticed in brain scans that ADHD brains develop 2 to 3 years slower than typical brains. And so when we talk about neurodevelopmental, it's not only the motor development of a child, the psychological development, but it's the development of your brain at the speed at which that develops. So when you think that your brain isn't fully developed until around 22 plus or minus, you can understand why ADHD children, certainly in the adolescence, tend to be much more impulsive because, as Amy said, the prefrontal cortex has not fully developed, and it's still trying to figure out what's appropriate and what's inappropriate within the environment they're living in.
That's an important distinction. Thank you. I found that very helpful. So David, you talked a little bit about this already, but we've got a few questions on it, so I think we may need to elaborate. Can you talk about how chronic cannabis use may impact ADHD symptoms?
So chronic cannabis. I'm sorry, I'm having a brain because I'm old enough to remember when cannabis was illegal. It was widely available, and its potency was substantially less. The difficulty with marijuana now is that it's not marijuana from 40 years ago. So the potency of THC in marijuana is 6 to 10 times higher than it used to be. And as a result, chronic marijuana use causes reductions in motivation, decreases in mood, cognitive slowing of information processing. And so over a period of time, people who are chronically using marijuana will notice these kinds of deficits. Now, they may not notice them because they develop quite slowly. But if you took a before and after, they would have to conclude that it's causing problems. The other issues with marijuana is that some people are at risk for developing psychosis as well. So the first thing to acknowledge is that the potency rate of THC in marijuana is substantially higher, which is why it's accounting for more problems when we look at patients in research than perhaps it did 40 years ago. Not to mention the issues with driving, impulsivity, concomitant substance use. So if you're more likely to be using chronic marijuana, you're more likely to be abusing alcohol, you're more likely to get involved with other illicit drugs, whether it's psychedelics or opioids.
Thank you. That's helpful. Okay, our next question. Can someone comment on how, if you can, to differentiate between inattentive and hyperactive symptoms could be largely driven from complex PTSD trauma symptoms versus ADHD in a person who has known complex PTSD? I hope I phrased that correctly. Tamara, anything to add here?
Oh, no, that's a David and Amy question.
Okay.
I'll pitch it to them.
Your head.
Oh, I am shaking my head because that is a very good question.
Great.
So I'll tell you the research here, and you can start at that point. There's an older research paper doing an analysis of pediatric and adult trials where they found that ADHD individuals were 3 times more likely to have PTSD to a traumatic event than a non-ADHD individual who had the same traumatic event. That's interesting. So for people, clinicians working in PTSD clinics, it really would be important to assess for ADHD to see whether the patients have it. So we're looking at the research population. The clinical population might be different in that it may actually be higher in the clinical population. So they do walk hand in hand. But again, PTSD is temporally related to the traumatic event, whereas ADHD is something that started in childhood and early adolescence. Now, the next question, of course, the person is going to ask, what if the child had suffered a lot of abuse in childhood and early adolescence, and now the picture grows that much more complex? So it probably requires a period of time for the clinician to sort out what symptoms are a function of the PTSD and what symptoms are a function of the ADHD. But it's easier to evaluate the ADHD by putting them on medication and seeing what symptoms improve and then what the residual of the PTSD is.
And I would add that trauma, chronic stress very much impairs prefrontal function, and it erodes prefrontal connections. And indeed, there's evidence that the severity of symptoms of PTSD correlate very strongly with synapse loss in prefrontal cortex, because prefrontal cortex is providing top-down control of our emotions as well as of our attention and our actions. So having that thoughtful top-down control gets weakened either because you've had these stressors that chemically then cause this loss of connectivity, or in ADHD where these networks have not developed fully or are slower to develop. And so you can see then this vicious cycle that can happen. In my experience, I've heard that a non-stimulant like guanfacine can be particularly helpful when you have ADHD in combination with trauma, that's in children, because a stimulant can make the trauma worse. But I'm not aware if any of that has been done looking at the combination in adults.
Thank you for explaining that. That was helpful. Okay, let's move on to the next question. This goes to a topic we discussed a little bit earlier. So many women experiencing brain fog in their perimenopause or menopausal transition feel as if they suddenly have ADHD when it is estrogen and dopamine, I think was in the question. As a therapist, how can I support or validate them, but help them to understand the difference?
So very simply, the difference is ADHD, again, starts in childhood and early adolescence. If they didn't have any of these symptoms through adolescence and early adulthood, then it's not ADHD, it's cognitive changes from perimenopause. If they have ADHD and their cognition is worsening during perimenopause, then it's probably a combination of both factors that are additive and making the symptoms appear experientially worse. And that's how it would make the distinction.
And, you know, studies in monkeys who also experience menopause have actually shown that the connections in prefrontal reduce during menopause and that they're restored with cyclic estrogen, low dose. So David was mentioning earlier how he often works with the gynecologist to see if hormone replacement therapy will help. And I can say it did help the monkeys.
It's a ringing endorsement.
Thank you, Amy. Tamara, did you have anything to add to this one?
No, I just really appreciate that we're talking about women and ADHD. It's been a population that we've seen come through the center who just need a lot of help. The therapist who wrote the question was saying how best to support. I would suggest asking her client to remain curious, not to become foreclosed with any decisions. This is my ADHD. This is my, perimenopause. This is, but to be curious about what she is experiencing and to teach herself to ask questions rather than to make demands of herself that perhaps she can't meet.
Thank you. So here's a good one. What are the current understandings of the overlap and distinctions between ADHD and autism, particularly regarding diagnostic criteria, shared neurological underpinnings, and co-occurring presentations?
Your audience is fairly sophisticated in their
Yes.
questions they're asking today.
Yes, they are.
So prior to 2013 and the DSM-5, you could not make a diagnosis of ADHD in an autistic individual. Now, keep in mind, there's a range of autism from nonverbal autism in children to what we used to call as Asperger's, high functioning autism. Also, there is a separation between intelligence and autism. So you ought not presume that somebody who's autistic has a lower IQ. That's been shown not to be true, especially in adults. The association between ADHD and autism is about 40%. So of those with autism, about 40%, up to 40% will have ADHD. So the way I deal with this is if I have an adult with high functioning autism who appears to have lifelong ADHD, I'll treat the ADHD. And what I found is that their functioning improves. That is, their cognition is better. They're able to follow through and finish tasks. They gain some degree of control over the verbal impulsivity and the low frustration tolerance, where they get overwhelmed and have outbursts. And I think that's very, very important to treat the ADHD in the context of autism. I will tell you, though, that if you think diagnosing ADHD is a challenge, diagnosing autism is really quite challenging in adults, in part because, as with ADHD, there's been no focus in the training programs on autism in adults. And so a lot of the kids who are clearly autistic get diagnosed, but those who are just a little autistic slip through and go into adulthood. There's also other comorbidities such as anxiety and mood disorders with autism. And so sorting this out, what's a cognitive symptom, what's a mood symptom, what's a social inappropriate symptom, and the inability to read social cues is really quite a challenge. I don't find autism diagnosed at initial evaluation. I have to really get to know somebody to understand the subtleties of their interaction with the world around them.
Great. Okay, last question. I am a Black pediatrician with ADHD who recently graduated from residency training, and I was taught dogmatically that adult ADHD was a controversial diagnosis. How can we mitigate this dogmatism that is pervasive in medical education?
This is what I call the Rip Van Winkle syndrome. That is, I got trained 30 years ago. I just woke up. And what I believe to be true 30 years ago is still true today. You're going to encounter people who believe it's a fad diagnosis. I grew up in an era of false memories, which later got neutralized as being an extreme. And this has been adopted in adult ADHD, in part because everybody responds to stimulants. So why do I need to put anybody on stimulant medications? My advice to this patient and person with ADHD, who, by the way, kudos to you for getting through medical school, being a Black physician, and you know that mental illness and mental psychiatric disorders are not well received in the Black community, as well as in the Asian and Hispanic community. And that's a whole nother discussion about ethnicity, culture, and the impact of making a diagnosis about ADHD. But what we need to do is to continue to educate our colleagues. As a physician, you're going to have the most impact on your patients. And kudos to you for bringing more skills to taking care of your patients. Your colleagues who don't believe in it will be marginalized, and those people who read the literature and consider the research will elevate their clinical skills.
Thank you, David. Amy and Tamara, anything to add there?
I might say that my experience is seeing that with the overwhelming amount of information that doctors need to learn, that some of them go back to Rip Van Winkle early times as a way of trying to have a simplified framework. But we need to be braver than that. and especially in the field of neurobiology and mental illness. There's so much now to be learned and to guide us and help us be both more compassionate and effective in treating people who need it.
Thank you, Amy. Tamara, any last words?
Oh, first of all, great job. You're one of us who there's no reason for you to succeed, and yet look at you. So that's great. And I'm sorry being flippant with the research, but whenever an ADHD person succeeds, I'm just so happy that they did it and they pulled through. Don't waste your time fighting the people who disagree. Go and be the change. And so you go forward, you're the next generation. Be strong and courageous.
Thank you, Tamara. Those were great last words. So unfortunately, that's all the time we have for today. On behalf of the National Academies, I want to thank all of our great panelists. Thank you so much for your time and expertise. I also want to thank our audience members. We know it's not easy to attend, but thank you for joining us. And please sign up for our email alerts at the top of the page you're on right now. If you scroll up, you'll see a box to sign up for email alerts. We're hosting a special edition Healthy Exchange series starting next month. It's going to tackle avian flu. So that's one you don't want to miss. So everyone have a great day and thanks again.